Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, Professor of Medicine and Infectious Diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, March 20th, 2025, we are speaking to Dr. Annemarie Wensing, a clinical virologist at the University Medical Center Utrecht in the Netherlands, and an honorary professor at the University of Witwatersrand in Johannesburg, South Africa. Dr. Wensing is a secretary of the European AIDS Clinical Society, or EACS, and chair of the IAS-USA Resistance Mutations panel and program committee member of the CROI conference. Her research focuses on HIV reservoirs and cure and on transmission and mechanisms of HIV drug resistance. Today, Dr. Wensing is going to discuss the recently released IAS-USA 2025 update of the drug resistance mutations in HIV. Annemarie, welcome to the podcast.
Thank you so much. I'm delighted to be here.
Well, it's great to have you. And one thing we share, in you more than me, is a long history with Dr. Charles Boucher, who sadly passed away several years ago, but was a real leader in the field of HIV drug resistance. Could you just describe your career path and the role that Charles played in your development as an investigator?
Yes, for sure. I met Charles in the clinic, and he was talking about a bright student. And I thought, oh, if this guy is going to talk about a bright student, who would be that student? And it turned out it was me. So I was really happy with that. And he hired me, and I did my PhD under his supervision. And that was very exciting. He was a visionary, never boring, every day a new idea. Also, I had some other supervisors who helped me a little bit more with structure, which was good as well. But he was really a very special person to be with. Yeah.
Well, just a real leader in the field, but just a sweet, wonderful guy. I mean, you could talk to him about any topic and it would always be interesting. And he laughed a lot and made people feel good who was around him. So really miss him. In some ways, we can dedicate this podcast to him. So digging into the material that he was very interested in, that you've picked up on and carried forward with him and then later in his legacy, is about resistance. How does resistance to HIV drugs happen?
Well, resistance doesn't really happen, and the virus is so diverse. I know it's a forbidden word, but the diversity of the virus actually already gives us that every mutation is already present. So it's just much more a matter of selection. And it just means that any time that a drug is not optimally present and the virus can continue to replicate, this mutation can be selected, but the mutation is already there.
Yeah, and I remember when I was coming along as a fellow working with George Shaw and Beatrice Hahn, the first project I worked on was genetic variation. And what we discovered was that in a person who's chronically infected with HIV, the virus is mutated and it sort of escapes the immune system, kind of like a cat and mouse game, that the virus comes in, the immune system responds, starts to suppress, and through the billions of viruses that are produced every day, mutations spontaneously happen. And if one of those mutations is able to escape the immune system pressure, it emerges as the lead virus, much like Darwin would have predicted in the 1850s. And so it's very much a survival of the fittest situation. And what I'm hearing you say is that with drug resistance, it's kind of the same thing, except in the case of drug resistance mutations, the virus is not escaping the immune system, it's escaping the pressure of the drug.
It's very much the same. Yeah, indeed. We often talk about immune escape and antiviral escape.
Yeah. So moving to how we use drug resistance testing, we have two different types. We have genotypes and phenotypes. Could you briefly review how we use those in practice and what they entail?
Yes, of course. I think the genotype we use most often in clinical practice because of reasons of practicability. But if you have a new drug, we don't know which mutations are going to be important. And then you really need the phenotype to help you to assess these patterns. And once you know, you can go over to the more easy, applicable genotypes. And then, of course, you have nowadays the NGS, so the next gen sequencing, which is more sensitive than the Sanger sequencing that we had 2 decades before.
Right. And so if I'm a pharmaceutical company, I've developed a new drug, I want to see what mutations might evolve, I will do passage experiments, right, in cell culture, where I would take the virus, infect the cells, and then add a low level, not to suppress replication, but enough to interfere. And then you watch and see which viral mutations emerge. And so your group collects that information and then correlates what mutations might have been seen in the in vitro experiments in the lab to what might actually be emerging when the drugs are used in practice.
That's correct, but that's a very laborsome kind of work. And also, it may very much differ in which setting you do it. So it's more difficult to standardize than the genotype. So an essential step in the beginning, but not so essential anymore if the drug is better known and we know more about the resistance profiles.
Right.
Although for some drugs that we do not have a very clear correlation with specific mutations, the phenotype is still the only thing that you can do to assess susceptibility to that drug.
Right. So the phenotype is that in vitro passage or the what's seeing what emerges, but the genotype is what we tend for most drugs to use in clinical practice, one, because it's more readily available, a little bit less expensive, but it does take some expertise in terms of how to interpret it.
That's correct, yeah. But luckily, we have some computer tools with smart minds behind it that can help and assist us.
Yeah, so maybe AI and that type of thing being applied. But with your group, with the IAS-USA, the mutations group, or we call it the Muta panel, tell me, we have a new recommendations or panel chart that just came out. Take us inside the conference calls and the discussions online in terms of how you go about creating these muta tables, the tables that have each drug listed and with the major mutations and minor mutations kind of listed out over to the side. How do you guys operate?
We operate under the supervision of the IAS-USA, which is instrumental. And what we then do actually is we kind of email each other the whole year, like, this is new. Have you seen this? I saw this poster. I heard that. Like a little bit of the nerds who like to talk about resistance together. And then once in a while, we really assess all new literature systematically, everything that's published, everything from key conferences. And we actually weigh all that evidence and then have vivid discussion on which mutation should be which weight on that bar. And then we come up, if there's enough news, with a new addition.
And so the most recent one that came out, it now includes not only the historic medications like the nucleosides, non-nukes, protease, and integrase, but this one also includes the capsid inhibitors, lenacapavir. Um, Maybe dig into the weeds a little bit more because of a drug that really hasn't been used that often. How did you all come up with the mutations to list for that?
Yeah, that's really difficult. And we also had discussions about that because there are like mutations that have been observed in the in vitro experiments that you just described, but have not yet been observed in clinical practice. And we have decided if they have a really heavy weight, already to list them because it will take some time before we have all the clinical information. So that means we have to work a little bit differently than before. We want to be have the information timely there, really to help guide the clinicians.
Yeah. So working in a clinic like you for many, many years, this notion of resistance in interpreting genotypes is something that most clinicians feel a little bit nervous about, because back in the day when we had AZT only, people could sort of see the mutations and it was clear the drug was failing. Then, as the triple drug therapy came up, especially with protease inhibitors, where it wasn't just a single mutation like it might have been for efavirenz with a K103N or nevirapine with a Y181C, this was a bunch of different mutations that gave partial reduced susceptibility, but the drug could still work. So clinicians are a little bit turned around in terms of how to interpret these things when the viral load starts going up, and it's clearly not just an issue of adherence. Um, what's your best advice on how clinicians, A, can learn about interpretation, and B, tools that they could turn to maybe online that could help them interpret their resistance mutations?
Yeah, I think what we have learned over time from studies that if you make a blind switch and there is resistance, that can help, but it's not often not the best route. If you use an interpretation system, you do better. We also know that actually, if you ask a virologist, a virologist is not really better than the interpretation system that you can choose online. So they're like as good as we are. We're not that special. However, if the virologist uses the interpretation system, we have learned you actually get the best as a result for your patient. So in that way, I think it's always very important if you have a resistance report to see if somebody has really interpreted it on the individual level, because that can really help you to get the adherence. If that has not been done, I would say just contact an expert, because most experts actually feel really flattered, if you ask them about the case. And there are not so many cases anymore with difficult resistance. So people really, also often excited to help you. But of course, you can also do a lot of things yourself. What I always did, if I put out resistance reports, I used actually two systems. I always use Stanford, which is a phenomenal system made by Boucher. But there's also in Europe a German system. It's made by a group of German people. It's called HIV Great. And I actually put both interpretation systems in my reports to show my colleagues who were treating the patients, for you, it's not really an assessment, it's a prediction. If you see two different algorithms next to each other, you more realize, that it's an interpretation and it's not a black and white thing. And you always have to be careful, because you would like to take everything into account, but you also want to have enough options, non-toxic options. And the problem is, if you weight resistance too heavy, you may end up with a perfectly virological, active regimen, which is not something any person with HIV could take.
Yeah, it's just too toxic, perhaps. And we've encountered that a lot. I think the good news is, as you just alluded to, that back in the mid 2000s, we were seeing a fair amount of resistance. And then the integrase strand transfer inhibitor drugs came along, and they were maybe almost an order of magnitude more potent than anything we had seen. So you can't use them alone, because ultimately resistance will be selected for. But if you combine them with two, but even one other drug to which the virus is susceptible, that's something that can be successful over a long period of time. But what it translates into clinic is that we don't see resistance that much anymore. And so the anxiety of providers as they encounter a failing regimen in a patient, they get a little bit anxious, maybe more than a little bit, about how to interpret. And so I think your idea of going to the Stanford database or some other algorithms is really quite helpful. One of the things that I've noticed, though, is that simple things like the M184V mutation for 3TC or FTC, that a lot of times that mutation really hampered the virus when it was paired with, say, a nuke or non-nuke, or maybe some other nukes. But with integrase inhibitors, it doesn't seem to be quite as much of a barrier to successful treatment. How do the clinicians keep up with that? Is that part of the mutatable, or is that just experience or using algorithms?
Well, if you want to learn more about these processes, I think the mutatables and charts are really good because there in the footnotes, there's explanation of these exact processes. You can really learn about that. I think most of the algorithms take into account the effects of this particular mutation because it can be beneficial. It was beneficial back then with the TAMs, the ACT mutations. But it's also beneficial in combination with tenofovir. And it's part of the success of tenofovir. Even with resistance of tenofovir, there can be added value if it's combined with lamivudine or anthracitabine, and this mutation is present. So I think that kind of thing is really something that the interpretation algorithms do. And if you want to learn more about the background, you best take the IAS-USA tables.
Yeah, and we can access that. We'll have listings at the time the podcast is published, but it's at IAS-USA.org, and you can go to the website there and find the mutation tables. It's also in the journal Antiviral Therapy as a specific topic in the paper, and describes what the new mutations are. One thing we didn't talk about, because I want to segue over to DNA analysis, is one thing we didn't talk about is that a reminder to everybody that when we order a genotype, we're ordering it off of plasma, and so it's a circulating virus that's present in the plasma at the time the blood's drawn, and then the lab will amplify and then sequence the virus looking for these mutations being present and list them. So that's looking at plasma. We want to have about a 500 copy per mil or so amount of virus so that you're sure that it's going to be amplified. Is that still the current recommendation?
That is still the current recommendation, but what we have seen, and I think that's especially often the case in the US, that you don't always have the complete history of an individual. And there was their failure in the past. I think the advice is still look whether you have historical genotypes, use the IAS-USA mutatables to see what's possibly could be, selected during these failures, and make a new regimen based on that information. However, you see a trend of using DNA because people think, that the virus is archived in the DNA. Let's do an HIV DNA resistance test, and I get insight in the archive. Theoretically, that's a fantastic idea. The problem a little bit is that most of the viruses in the DNA are actually not, as you just said, actively replicating. Often, these are just viral variants. So you may overestimate resistance by using a DNA test, or even because only part of the archives, you can select by doing the test, can also make an underestimation of the resistance. So the test is not as ideal as an RNA test. There are certain indications when you can, if you have enough knowledge about the limitations, you can use these tests. It's rather complex. So I think it's really important if you get a DNA test that there is somebody with proper knowledge who has judged it. And I think very helpful in this perspective, we have a new paper, it's in press, in Clinical Infectious Diseases, with all these caveats and also some recommendations when you want to perform or want to order an HIV DNA test, resistance test.
And a lot of times that's come up, as you just alluded to, where you don't have the full history of antiretroviral therapy. We know that when you check plasma, it's going to tell you what's present now, but it doesn't tell you what the patient may have had. So that is kind of like an archaeology trip into the cell to see what was there. But sometimes we're trying to switch therapy while somebody's virally suppressed, and we want to either simplify a regimen to 2 drugs, or we want to deal with the toxicity that maybe one of the drugs is having. So you might get a DNA test there. Do you think, let me put it this way, in what settings would you rely on a DNA test and feel like you're getting good information?
I think if you have no historical information, it is something that you can do, but you have to very thoroughly check the sequences that you get from this, because there may be a lot of viruses that are actually not replication competent, and they can give you false mutations. And it takes some expert analysis to be able to put these sequences apart. And that may be difficult if you're not doing that on a daily basis.
So for the average DNA test, you're not going to be able to tell if a given mutation was read out from the DNA, whether it was part of a fragment of a virus or whether even if it was full length, that virus was replication competent.
Yeah. And there are some tools to work around that. And for instance, you have to check for Appleback-induced mutations. And Appleback is actually an innate defense mechanism that our immune system has. And it changes the virus in a way that it becomes replication incompetent. But some of these changes look like resistance mutations. And it has to be actually on the report. You have to be able to see whether there has been a check for these Appleback mutations. Because otherwise, you may deny an individual certain options that would still be valid for a person.
So I think the take-home point for clinicians, and it sounds like from my understanding of what's in your paper coming out in CID in a few weeks to month or two, is that the DNA test is nice to have as an option, but if you order it, interpret with caution. Is that fair?
I think that's very well said.
Let's maybe start to wrap up with something that I saw at Croy that I couldn't quite understand and was hoping you might be able to enlighten me on what the meaning was. There was a paper presented that had to do with, I think it was dolutegravir resistance, but was not coming from the site within the virus that you would have expected, where, in the integrase gene product. Yeah, rather it was sort of off target, if you will. I don't know if you saw that paper, but can you help me understand how something outside of the main target region might actually influence susceptibility of a virus?
Well, we have many people that actually are not many, but maybe a considerable percentage of people do not get well suppression on dolutegravir. Then there is mostly dolutegravir because that's the most used around the globe, but also with other instances. And what you actually see is that you get vivid discussion about adherence. And in some cases, indeed, if you do a drug level assessment, there's no drug. With some people, you have evidence of the drug being present. There are no known resistance mutations in integrase, and still the virus continues to replicate. And in a subgroup of these people, they have found mutations elsewhere. It's not the first time. We have seen that also with other drugs. Mostly, these resistance is very subtle. And so we often have said, well, we know it's there, but it's not really of clinical importance. Now it seems that it's maybe a little bit different with integrase inhibitors. I think we still need more evidence, but it has been reported now more often. Last year it was just more an in vitro analysis. Now we also see some clinical proof, and it happens really in the clinical practice. And now we have to see how important is it with good adherence? Could it really, really influence our clinical decisions? And it may be. So we have to really to watch this and follow this.
Yeah, and my experience so far is that I think it's fair to say that most often, in fact, almost every time that I've used strand transfer integrase, either Biktarvy or dolutegravir, it works well. I mean, there's not a problem with virologic failure. The couple times where I've seen it not working was more of a pharmacokinetic problem where a divalent cation was present. And so I'm wondering whether in these clinical scenarios where they've identified dolutegravir drug failure in the absence of resistance mutations, whether it could have been something like that, or do you think it's more of a virologic issue?
I think it's very often an adherence issue, but not always. And I'm sure, the virus always finds its way, whether we like it or not. And I think it will not be different with the entity. So I think it's very likely that processes elsewhere influence infectability or other process that in the end will make the virus less susceptible to the drug.
Yeah. Well, as I anticipated. Our time has just flown by. I really appreciate your insights. Any predictions about the future, the next 5 years of what you expect to see as we use more long-acting agents and what that might imply for emergence of drug resistance and how we might be tackling those challenges?
Well, what we see is that we have a variety of drugs. I think over 40 drugs have been approved. But we see that for reasons of toxicity and efficacy, the group of drugs that we use becomes smaller and smaller. And that means that more people globally, rely on the same drugs. That means that any resistance problem will also be amplified. And even if these drugs are extremely powerful, well designed, I think, unfortunately, I cannot retire yet. I really think we're going to see some more issues with resistance. As some of the new drugs don't have a very high barrier to resistance, so resistance can be easily selected. I think the way of, the long-acting will also prevent a lot of adherence issue. So it will somehow counterbalance. But I really think there's more work to do. I know the companies are working on it, but we also have to keep pace.
Well, thank you very much for joining us, Annemarie. I don't think you have much of a challenge with job security over the next decade or two because drug resistance will remain with us in some way, and your leadership in helping us understand drug resistance and how to assess it and manage the patients that experience the drug resistance problems is extremely valuable to all of us. And so thank you for joining us, and thank you for all the work that you do.
Thank you for having me. That's very nice.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.